Very good. Well, firstly, welcome to the 13th Poach Key Thinkers Forum that we're going to be presenting today. As we've mentioned, you would have seen in the literature that this is being broadcast live, and so we just had to get everybody online, and we're having one of our presenters will be coming in from Canada. Unfortunately, couldn't make it, but I'll talk a bit about that in a moment. My name's Tom Kalmer. I'm going to be host for today's event and run the proceedings. But can I begin by acknowledging we're in the land of the Kaurna people and pay respects to Kaurna elders past and present, and also recognise the Kaurna youth, as we do with all youth who are going to be our future leaders, the custodians of our stories, our cultures, our histories and our languages. And it's incumbent on all of us to help grow up our youth and create the pathways and encourage them to do so. But it's my privilege to welcome Alan Sumner to come and do a welcome to country on behalf of the Kaurna people. Alan.
Thank you, Tom. Namane, Nainari Yartu, Nakaramero, Negarna, Naringari, Yankurindari Yarta, and Nawangani Mani Nabudni, Garna Yarta, Tanda Nangyakan, Necha Yakandalia, Nachalia. Greetings to you all. Hope you're all good. Are you all good? Yes. Wonderful. I said I'm the firstborn son in my family. I come from this part of the country, Kaurna country, but also my father's country, which is Ngaringiri, and my grandmother's country, which is Anangu, Yankurindjara. And so I said that is good that you are here on Kaurna country. We don't have a word for welcome. We simply say it is good that you are here. So on behalf of my ancestors and my family and Kaurna family groups on the Adelaide Plains, I'd like to say that it's good that you are here on Kaurna country. So Nachalia, thank you very much. I'm looking forward to being part of the forum and listening to what everybody has to say. It's going to be fantastic. So thank you very much. Nachalia.
Well, thank you, Alan. And can I say that this is, as I mentioned, a Poach Indigenous Health Network Key Thinkers Forum, and it's the 13th, and we host them a couple of times a year, but this year we're into the third one. So because it's such an important event, and this is, for those that don't know, there's a little bit of info in the literature that's out there that philanthropist Greg and Kate Poach have donated $10 million each to 5 universities around Australia to do research and other activities associated around Aboriginal and Torres Strait Islander health. And Flinders University is one of those universities who are recipients of that funding. And so this event is hosted with Flinders University, and I'd like to recognise Professor Dennis McDermott and Liz Larkin, who pulled this together with other Poach centres. We have the directors, I think, of all the Poach centres here, from University of Sydney, University of Melbourne, UWA and University of Queensland, and of course I mentioned Flinders. Our topic today is a very provocative one, one that I think is going to really draw some interest out, not only from you guys, I hope, but from where we're broadcasting to, and we will be getting questions come in. The format that we do it is in a sort of a Q&A, come insight event where we'll have some presenters, and then after the presentations we'll go into the Q&A style, and so we encourage you to ask questions. There will be a roving microphone, if you can just wait for that to reach you, because it is being broadcast, and we want those who are around the globe who are watching this event live to be able to hear what your questions are, and we'll hear from them what their questions are as they do it, and Odette will be collecting those and passing them up to me to ask you as we go along. The topic is really ousting unconscious bias, and Why unconscious bias? Because it's with all of us, and we'll hear a lot more about that. And it's a big influence on the way we do things, and whether it's conscious or unconscious. It's worse if it's conscious. It's still bad if it's unconscious bias, but it's an issue that we have to look at. For us in Australia, as we are with Indigenous peoples around the world, are affected fairly significantly by racism and discrimination, stigma, and they prevail across many sectors, but particularly in the health sector that we'll be focusing on today, because it can be a life and death situation. And I hope we draw out issues from the Australian perspective, issues like Dr. G. Unipingu in Darwin, who was treated very poorly because people thought that he was, he suffered from alcoholism and there was no urgency in treating him, and yet he passed away because he had a chronic kidney condition that wasn't treated. You might remember Miss Do in West Australia, who was in a police van, complained about having abdominal pains, and went to hospital 2 or 3 times, and was poorly treated, released, and said she'll get over it. Passes away in the cell. It just wasn't good enough, and but we have seen some progress. The Australian Indigenous Doctors Association have put out a big report about discrimination in the health system, in the hospital system, raising awareness. We saw back in July, during NAIDOC week, the Police Commissioner Chris Dawson in West Australia giving an apology to all Aboriginal people because of the conduct of the racism and the unconscious bias that's been perpetrated by the West Australian Police Force, and undertaking that they're going to address that and try not to do it in future. But I think what we're going to hear from 3 very distinguished speakers about the issue, but also maybe some of the solutions or the issues that we as a population, as a sector, have to contend with. And their bios are here in the little handout that we've got there. But I'll just introduce our first speaker, Dr. Ricci Harris, who's talking from New Zealand and Wellington, a researcher with the University of Otago and also Auckland, senior research fellow. And so Ricci will be first up. She'll be followed by that little person in the screen up there, Barry. Barry, who's Dr. Barry Lavalley, who's over in Canada, who was going to be with us, but unfortunately had a family issue that he had to address over there, and so couldn't join us, but very, very, I guess, graciously agreed to come in online. He'll tell you what time it is over there. I think it's in very early hour of the morning, but at least he's come through. And our third speaker is our own, Dr. Chelsea Bond from University of Queensland. And for Australians, we see Chelsea, recorded in a lot of the social media around in raising awareness about race and so forth. So I won't go into detail into their bios, but I think I'll take the opportunity to invite Ricci to come up and do her presentation, and then we'll slowly go through and with the others.
Tēnā koutou katoa, he mahi nui tēnei kia koutou. Good afternoon, everybody, and warm greetings from New Zealand. I'd like to begin by acknowledging and pay my respects to the Indigenous people whose lands we meet on today, the Kaurna people. He mahi nui tēnei kia koutou, and thank you, Alan, for that very warm welcome to country. He mahi nui tēnei kia koe. I'd also like to just thank the organisers, especially Dennis and Liz, for inviting me to talk on this really important topic today, and also like to acknowledge my co-presenters today, Dr. Chelsea Bond and Dr. Barry Lavalley. And thank you also, Tom, for that warm introduction. So just a little bit about me. I'm Māori, from the tribes of Ngāti Kahungunu, Ngāti Raukawa and Ngaitahu in Aotearoa, New Zealand. Professionally, I trained as a doctor, and then specialised in public health medicine. And for a number of years now, I've been working in research. And the focus of my research really is on Māori health and inequities, especially looking at how racism is a health determinant and driver of those inequities for Māori. And so I've really come to look at this idea of unconscious bias from that perspective. And the theme of today is outing unconscious bias. I sort of purposefully called my presentation racial ethnic bias among health providers because I sort of don't want to really leave out explicit bias, which I think is still a problem. And I was asked to sort of set the scene a wee bit. So I'm going to talk a bit about the field in general, as well as some specific research that I've been involved in New Zealand, and hopefully provide some ideas on moving forward, but also a few points of caution from my perspective. Just let me get my Harry Potter on. Okay. So in New Zealand, we've got long-standing systematic health inequities between Māori and New Zealand European, which is the dominant ethnic group, numerically and in terms of power, across most major health indicators, including in the access to and the quality of healthcare. And we're not alone in this pattern of inequity for Indigenous peoples, with similar histories of ours as, in terms of colonisation and oppression. And similarly, most of the research and explanations for these inequities have focused on us, what it is about us, about our communities, about our culture and about our behaviour that cause these inequities. And that leads to a really vicious cycle that produces and reproduces explanations of inequity that problematise us. In contrast, the role of healthcare systems, services and providers has been relatively under-examined and is often only implicated by inference using indirect evidence. So in 2013, this report, Unequal Treatment by the Institute of Medicine, was published. And it's a US-based report looking, of a comprehensive analysis of sort of systematic inequities in healthcare by race and ethnicity. And it has been quite significant because it highlighted the role of healthcare providers and health provider racial ethnic bias in these inequities. And it has been influential in terms of shifting the focus a wee bit. So now this idea of health provider racial ethnic bias and its role in contributing to health inequities is receiving a lot more attention. And there's a growing body of evidence examining and measuring health provider racial ethnic bias, particularly amongst physicians, but also in other health professionals such as nurses, occupational therapists, pharmacy, counselling, as well as students in those areas, trainees. The research is almost exclusively US-based, though, and it consistently shows a pro-white bias amongst healthcare providers relative to a number of non-white populations. So pro-white implicit bias or unconscious bias. The measures of explicit bias, on the other hand, tend to be sort of much lower or non-existent. And racial ethnic bias has been shown to affect the way that people behave, not just in health, but in other areas such as employment, education, policing. So what do I mean by bias? So this is a definition by Michelle Van Ryn and colleagues, and they talk about bias as generally negative feelings and evaluations of individuals because of their group membership, overgeneralised beliefs about the characteristics of group members, and inequitable treatment. So it encompasses beliefs, feelings, judgments and actions. And within this broader definition, we can sort of consider bias to be explicit or implicit, and the explicit and implicit aspects relate to sort of the mental processes that we use to manage information. So explicit bias is considered conscious and intentional. They're the thoughts and the feelings that people deliberately think about and can make conscious reports on. And we measure them in research as self-reports, but they are also subject to sort of under-reporting because of social desirability. Implicit bias, on the other hand, often exists outside of our conscious awareness. So it can be difficult to acknowledge and control, or consciously acknowledge and control. It's often automatically activated without us even being aware of it. And there's various ways to measure that. One of the most common ways is the implicit association test, or the IAT. And I'm just going to talk a little bit about that because I want to talk about it later as well. That's a sort of response latency test that you do on a computer, where you have to rapidly sort stimuli from different categories, like images of people from different ethnic groups with sort of positive and negative words, and the difference in speed with which people can sort various combinations gives a measure of implicit bias. In terms of implicit and explicit processes, in our daily lives, we normally use we use implicit biases more often than, not implicit processes more often than explicit processes, just to deal with the vast amount of information that our brain takes in. So they're faster and more, implicit processes are faster and more efficient. So I tend to use the term implicit bias, but it's the same as unconscious bias or unintended bias. We learn these biases from a really early age over a long period of time, and they can become quite entrenched, but they're also malleable. And racial ethnic bias is one form of bias, but we can have bias towards other sort of social categories like gender, sexuality, social class. So what drives health provider racial ethnic bias? I think it's really important to talk about racism. Individual level racial ethnic bias is, I would say, is a manifestation of racism. And when I talk about racism, I mean an organised system that structures opportunity, resources and power by race and ethnicity. And in Aotearoa, New Zealand, racism is really foundational in our colonial history. I see it as intimately linked to colonisation, and it's maintained over time through structural factors that perpetuate that initial historic insult. So racism then underpins the construction and maintenance of those sort of common sense beliefs about racial and ethnic groups. So individual health providers' ethnic bias sort of reflects those racialised discourses and stereotypes, that we're often and constantly actually exposed to in broader society, but also in our health learning institutions and healthcare institutions. So as health professionals, we're not immune to those messages. And they influence the way that we interact with our patients. So I think it's really important to talk about racism in this process. And I just wanted to actually spend a little bit of time talking about a couple of sort of common discourses that are often talked about in association with implicit bias in particular, that I think can be a little problematic when we're talking about racial ethnic bias. The first idea is that it's normal and natural, and we all have biases. So the implicit cognitive process is totally normal. We all do that. And maybe we do all have some sort of bias, but actually not everyone does have racial and ethnic bias. And we know that from the evidence that it varies by ethnic group. And the normalisation, I think, of bias can be a bit problematic when we're specifically talking about racial and ethnic bias, because it fails to recognise the processes that lead to that bias. And it also may inhibit our responsibility to act. Secondly, there's this idea of bias being about liking people who are more like us, and not liking people who are different to us. So this idea of in-groups and out-groups, though, is not just about our individual identities. It's also about how society values particular groups by race and ethnicity. So we know in studies that amongst health professionals that white participants tend to constantly show anti-black implicit bias on average, whereas black health professionals tend to show none. Also, from studies in the US, we know that other racial and ethnic groups also demonstrate anti-black bias, suggesting that the way that society values groups by race and ethnicity is really important. Finally, there is sometimes a reluctance to name racism in this process for fear of people disengaging or making people uncomfortable, which I think is problematic. And the quote that I've used here is from a paper by Michelle Van Ryan and colleagues, and it's worth a read because it talks about their model of how racial and ethnic bias amongst health providers affects health inequities. But it's an expansion and critique of a model that they published about 8 years earlier, in which they purposefully focused on physicians' reactions to patient race or ethnicity rather than racism for this precise reason. But in doing so, they realised that they'd ended up reinforcing notions that the problem was with patient race and ethnicity, rather than the more sort of accurate process of how racism affects health providers' attitudes and behaviour. So it's really important to situate racial ethnic bias in the context of racism and in New Zealand, our colonial history. It specifically avoids locating the problem with us as Māori. It's more explicit and compelling in the responsibility of healthcare organisations and providers to act to address unjust processes, and it has important implications for addressing racial ethnic bias. So in this wider context then, how does individual health provider ethnic bias contribute to healthcare inequities and health inequities more generally? So this is a simplified diagram of sort of the two main pathways that provider racial ethnic bias is thought to cause disparities in healthcare. It's for implicit bias, but it works just as well for explicit bias. So providers' ethnic bias might affect their clinical decision making, leading to disparities. But provider racial ethnic bias may also impact on the health encounter by negatively affecting the way that they communicate and interact with patients. It subsequently can affect patient behaviour and feelings, and also interact with their judgments and decisions about patient care. And there's been a few review papers now and studies directly examining the link between health provider bias, particularly implicit bias in healthcare outcomes. And there is evidence to supporting these pathways, but the evidence base is not huge. The last review, I think in 2017, had about 25 studies. Again, they're almost exclusively US-based, and many use sort of a vignette-based healthcare measure to examine provider sort of management decisions by race and ethnicity. And they've had mixed results. A few have found an association between unconscious bias and clinical decision-making, but most haven't. There's been fewer studies that look at real-world patient care, but where they do, they seem to be more consistent in their finding of an association between bias and poorer healthcare outcomes. So that's things like poor patient-provider interactions and poorer physician communication styles. In New Zealand, we've got quite a lot of indirect evidence supporting the role of healthcare provider ethnic bias and inequities. So as I noted earlier, they quite large evidence base around inequities in healthcare access and quality, but also qualitative evidence of negative stereotypes about Māori and Māori health. So they're particularly strong around stereotypes around compliance and the sort of associated explanations related to that, like culture, socioeconomic status, and self-destructive behaviours. And in wider New Zealand society, there's also research documenting the existence of negative beliefs about Māori. Māori report higher experiences of racial discrimination, including by a health professional, and that's really strongly linked to negative healthcare measures. And finally, I just want to talk a little bit about the final study there called the Bias in Decision Making in Medicine study that I was involved in along with some other researchers and Māori medical educator colleagues. So this was a study that we did to more directly look at medical student ethnic bias towards Māori compared to New Zealand European. The motivation, I guess, for undertaking the BDMM study was to better understand the context of teaching Māori health in a racialised society, and to help inform educational approaches and strategies to sort of support learning around Māori health. Specifically, we wanted to examine medical student implicit and explicit ethnic bias and to look at associations with clinical decision making. So in 2014 and 2015, we invited all final year medical students in New Zealand, so we've got 2 medical schools, to participate in an anonymous online study. So we had 302 students participate in the study, which is like a response rate around 34%. And the study included measures of implicit bias, so 2 IATs, one looking at ethnic preference and another one looking at implicit stereotyping around compliance, as well as a range of explicit questions and treatment recommendations using clinical vignettes. So these are the results of the implicit measures. So we found ethnic bias favouring New Zealand Europeans compared to Māori, and was evident amongst medical students. So this is a figure of the IAT findings, and it shows the distribution of their implicit bias scores from each IAT. So the one on the left is the ethnic preference IAT, and the one on the right is the ethnicity and compliance IAT. So just to, the score of 0, so indicates no implicit bias. Negative scores are pro-Māori for each IAT, and positive scores are pro-New Zealand European compared to Māori. And each dot is a participant score. So for both measures, there's quite a wide range in the scores. And when we looked at the average, so for ethnic preference, the mean IAT score indicated sort of a moderate implicit preference for New Zealand European compared to Māori. And for compliance, the plot on the right, the mean IAT score indicated a slight implicit association of New Zealand European being more compliant than Māori. So this is the results for all of the participants. There were some differences by the ethnicity of the participants. So most of the participants were New Zealand Europeans, about 60%, a third identified with an Asian ethnic group, and 5% were Māori. So for New Zealand European and Asian participants, they tended to reflect the total population results, or the total sample results, but Māori students on average didn't demonstrate any implicit bias. Oh, that's my backup slide because that one always goes wrong. To a lesser extent, they also exhibited explicit bias. When I say that, most of them said didn't demonstrate any explicit bias, but where there was a direction, it was mostly in the direction of pro-New Zealand European compared to Māori. And so that was in relation to explicit questions on ethnic preference, warmth towards a particular group, and a range of questions that were used to capture sort of compliance and competence. In terms of sort of treatment or management options, we didn't actually find a very clear link between measures of bias and decision making, but there has been some more recent critique of the use of vignettes in these types of studies that may have impacted on our ability to actually detect how people might respond in real clinical situations. This is the only study that's been done like this in New Zealand, so we don't know if medical students' ethnic bias is similar to physician ethnic bias or similar to our wider population. But again, studies from the US show that medical students' bias and it seems to be sort of similar to physician bias and similar to general population bias. And given the common stereotypes about Māori and Māori health in New Zealand, we were not surprised by these findings. And it's provided some good information, really good information for us in relation to our medical programs and to medical student learning around Māori health and equity. And medical education, I think, can play a really important role in reducing and mitigating the effects of ethnic bias. So there's a study in the US at the moment called the Change Study, which is looking at this issue amongst about 40-something medical schools around the country. And they're sort of showing that introducing teaching on ethnic bias in the formal curriculum amongst medical students and sort of improving student confidence in providing care for minoritised populations has been associated with reduced racial and ethnic bias. I would say in New Zealand that the area of ethnic bias in healthcare is really being driven a lot by our Indigenous medical educators. But this actually can't just be the responsibility of those working in Indigenous medical education or Māori health. It has to be much broader than that. We have to try and tackle ethnic bias in our environments. So looking at our faculty, our policy structures and practices of our learning institutions as well. How am I going for time? This is my final slide. So I'd just like to discuss some of the more specific strategies to address health provider racial ethnic bias. This is even more limited in terms of the evidence, but there's really some promising strategies emerging for health professionals and organisations. And one, at the individual level, it sort of involves two main approaches. So the first one is sort of enabling providers to become aware of their racial and ethnic biases, and then strategies to reduce or mitigate expression of those biases. So one of the first critical steps in addressing biases, especially unconscious bias, is to be open to it and recognise it in ourselves. And that can be quite difficult for health providers whose explicit sort of attitudes and intentions may be the complete opposite. But based on the evidence that's coming out, we really should be saying, oh, this could be me, not, oh, that's not me, especially if you're from dominant ethnic groups. And there's critical sort of self-reflection strategies and tools like the IoT that can help people examine their implicit biases. But we also have to understand how we learn and take on those biases, and that requires us to engage with our histories and racism and how power and privilege operate and actually our own position within those systems. Then there's strategies that have been shown to help or reduce or mitigate expressions of racial and ethnic bias at the individual provider level. So there's things like individuation, perspective taking, counter-stereotyping, building partnerships with patients, and strategies to promote emotional well-being. But to be effective, they require a intentional, concerted effort over time. And they are somewhat limited if we don't also change people's environments. Again, a lot of this evidence is from the US, but I think that there's some really good Indigenous developed models and methods that align well with approaches to addressing racial and ethnic bias. So I'm thinking about the deconstruction exercise that Dennis and David talk about, and also cultural safety approaches to healthcare. There are also things that can be, or that can and should be done at the organisational level to support health professionals to work on their racial and ethnic bias. This particularly includes strategies to help reduce cognitive load, like adequate staffing, supervision and support, improve workflow, and cognitive aids like algorithms, checklists and guidelines. Monitoring and providing feedback is hugely important because implicit bias is so hard to recognise. It's really important to monitor our healthcare institutions in terms of how they deliver, how they manage if they can manage equity in terms of race and ethnicity. The more challenging thing is to identify and act on the institutional arrangements that reinforce racial and ethnic bias in existing power structures. And again, it requires a critical examination of the way that institutions operate and who they serve with regards to ethnicity, both in health but also in broader society. So as health professionals have got a responsibility to act to address racial ethnic bias, and it requires getting out of our comfort zone and shifting the focus. In New Zealand, that means shifting the focus away from Māori as the problem and critically examining ourselves as health professionals and our organisations and how we may be perpetuating inequity. Thank you.